Another exciting day here at the Texas Association of ACOs. We've seen everything from digital health to ACO operators, IPAs, CINs, investors, technology, you name it. And you never know what you're going to run into at a value-based care conference. I actually had the unique opportunity to visit with Laura Bunso from Smart Body Physical Therapy. Let's talk a little bit about the physical therapy, but also there's a little bit of a unique take on your practice. You want to share some more about what you do?
Yes, I think unique is an appropriate word for what I do. So our entire company is based on servicing pelvic floor physical therapy. It's very unique that it's not a side-on. It's not a side note or an addition to what would be a traditional outpatient orthopedic practice. It's typically a space that's been really challenging to service for the entire physical therapy community. It's obviously very needed. I shouldn't say obviously. It is very needed. There's a lot of demand for it, but it's very challenging to find someone who is actually well trained in it or specializing in it because it's not easy to administer. And a typical outpatient physical therapy practice can see 2, maybe 3 patients at a time,
Right.
Pretty easily. As you can imagine, pelvic floor physical therapy, we need a private room and gloves to do what we do. So it's not something we really even have a challenge of we can't really not even dovetail patients. You're finishing up in the private room and then they're going on to the next. So that presents a whole new set of challenges with the delivery of care when it's built on a fee-for-service that's set up for something that's designed around doing 2 or 3 at a time.
Well, and I want to talk maybe from your perspective, what you've seen and heard throughout the conference in terms of where that fits in value-based care. But before we do, help us understand a little bit more about your practice because, and again, I don't know this world.
Yeah.
But what was really interesting to me is that there's enough of a demand there to create a specialization and to develop a practice around it instead of being a supplement to another kind of broader physical therapy practice. So kind of help us understand referral sources, help us understand patient demographic and, male versus female, any other nuances that you're seeing in the space. But I'd love to hear that. And then we'll talk value-based care.
So we shifted gears about 12 years ago. My company won the Athena project in Jacksonville, Florida, which is for female-based business owners. And through that, actually, I was able to get a panel of experts that I probably, business-wise, wouldn't have been able to afford. And really evaluated and dug into, how could we deliver this in a way that was viable, honestly, versus just being the side note. So pelvic floor physical therapy in general is a spectrum. So you have you have something as common that you would probably think of recovering after a baby or maybe during pregnancy. People often think of a pelvic health therapist for that or pelvic floor therapist for that. Then you have someone with urinary leakage. So maybe you have a woman who's had 3 babies and she's got stress incontinence, which is when you cough or laugh and you leak. And we made a little tagline of if you dribble when you giggle, that's something that we can help you with. So and then there's urge incontinence, which is usually in an older adult, and it's where you get the urge to go, but you can't get to the bathroom in time. So there are certain diagnoses inside of the pelvic floor space that or certain demographics kind of fall into that. Those are things I think people probably think of pretty commonly for pelvic floor therapy. But then you have bowel dysfunction, and inside of that bowel dysfunction space. And no one really talks to you. None of these are things that you talk about at dinner, except I do, if people will allow me. So as everyone else finds out. So in the bowel dysfunction space and how it relates to pelvic floor therapy, and I think that this is actually one of the key places where there can be a lot of value added to value-based care. There's really nothing more life-changing if you've lost control of your bowels. Nothing will keep you home faster than if you have fecal incontinence, which is where you are losing stool and you don't have any control over it. If you are someone that is reliant on public transportation, you're not riding a bus if you have fecal incontinence. So this is something that could be a deterrent for someone going to their medical appointment. In addition to that, as far as bowel dysfunction goes, there's chronic constipation, And this isn't constipation like you went to Europe and ate too much cheese and didn't drink enough water. This is outlet dysfunction, which means that you don't have control over your pelvic floor muscles. So your pelvic floor muscles are striated muscle, just like your bicep. So it's in the musculoskeletal space, or MSK, as everyone says in this world. But these pelvic floor muscles are, they're voluntary muscles. So you are able to contract them and relax them. What's difficult about this is you can't see them. So you can't tell if I'm contracting or relaxing mine right now. I don't know what you're doing with yours. The only way to know for sure is to actually do an examination. And this does involve getting undressed and doing an exam where we do a vaginal and or rectal examination, depending on what's going on. That's the standard of care in the pelvic floor physical therapy world. But one step further than that is you have to be able to retrain the muscles if there is some dysfunction with them. So we get a ton of referrals from Mayo Clinic in Jacksonville, Florida, from the GI department. And these patients are coming because they're struggling with outlet dysfunction or chronic constipation. Some of these patients are so sick from this that they have multiple emergency room visits, and they're going with abdominal pain. They are, some of them have ostomy placements. There are a lot of different things, and this is a musculoskeletal dysfunction. This is someone with a very expensive medical intervention in response to something that we could, as clinicians and physical therapists, we're the cheapest part of healthcare that you're going to get. The salaries are very low in comparison with all of the other specialties or even primary care. And then our equipment is basically a table, and the most expensive component that we have in the pelvic floor therapy world is biofeedback. And so that's the piece that's really crucial and really challenging. So if I did a pelvic floor examination on you and I found, okay, John, you're struggling with this issue. You're stuck in your hotel room for 2 hours before you can get out here because you're struggling with this bowel dysfunction to go to the bathroom. And I can use biofeedback to help retrain those muscles, because me just telling you, this is how you contract it, this is how you relax it, is not good enough. You can't even look in the mirror and see, if you're a stroke patient and I'm teaching you how to move your shoulder again, you can look in the mirror, or even my jaw. I can clench it and relax it. I can look in the mirror. If I'm trying to retrain your pelvic floor muscles, there's really no way for me to know if you're doing it correctly when I've taught you, unless I keep my hand there that time. That's not practical. So we can use biofeedback, which is essentially like an EKG for your heart. It's a surface EMG. So it doesn't hurt. They're basically little stickers and or a vaginal or rectal sensor, depending on what's going on. And then the patient is allowed to see on the screen how well they're contracting and relaxing those muscles. We can use that. The bowel dysfunction is probably the most extreme example of that, but how less extreme might be helping someone have pain-free intimacy again, males and females. So we treat men who have pain with ejaculation, or afterwards we treat women who are unable to tolerate penetration. And so we're working on retraining these muscles so that they understand that they may be tightening them rather than relaxing them. And it seems mind-boggling that someone might have if you're contracting your bicep or not, right? You can have an idea. But for the pelvic floor, there can really be such a disconnect with those muscles, and people not have any understanding of what they're actually doing with them, that they need some guidance and help and truly rehabilitate the muscles.
Yeah.
Very, very recoverable. But without the proper training, I've had executives have career-ending pain because they actually had a labral tear of the hip and their pelvic floor is screaming and tension and tightening because it's the last thing they've lost this integrity of their hip, and they have the pelvic floor now is getting this extra load transferred onto it because the integrity of the hip is lost. And so we work with orthopedic surgeons as well. They've reached out to me. They're like, we're missing a piece of this. Something else is going on. But really life-changing things. And of course, what if your heart and your lungs and your brain are functioning, what's more important than peeing, pooping, and having sex? I mean, honestly, those are the top of the list for most people. Not what you're talking about, generally in public, but it really is, and it's life altering for people who are. If you're having an emergency room visit because you've got abdominal pain and you end up with a colon resection and an ostomy placement, And this could have been prevented if you had had the proper pelvic floor rehabilitation. And thankfully, all is not lost. If you do have an ostomy replacement, we've had patients have a reanastomosis once we did restoration of the function of the pelvic floor muscles.
Well, and it sounds to me like this is, and certainly not to equate it to working out and lifting weights, right? But a lot of time it's about the mind muscle connection, and that's how you get the
100%
best
it is.
result. And it sounds like that's the same mentality that you're taking to this. You're just getting that biofeedback to show when they've actually been able to make that connection.
Yeah, the stakes are just higher if you don't
100%.
get it resolved.
Yeah. Well, one is you're working out and you don't get as good of a result. The other is probably life altering.
Yes,
in
exactly.
the greatest of fashions.
No,
And
you're exactly
I
right.
think, I think you've kind of alluded to where you tie into value-based care and where I think there's opportunity. But, my question would be, how do people know that these resources exist within the medical community? Because this is the first time I've had this conversation, and I've been doing this for 15 plus years.
Yeah.
And then secondarily, what are those key indications where they need to get you involved early and often so that it's much more proactive and preventative instead of getting to the point where you're having some of the stories that you've articulated here today?
I think that's a really good question, and it's actually really what I came to this conference asking myself. And one of the biggest things that I think is we talk a lot in these conferences about, we talk about outcomes, we use that word, but we talk about costs and expense. But the other thing that we're not talking about that I think is really crucial to consider with all of this, because those things are kind of a given, right? You want the patients to have good outcomes, and we want to try to get ahead of things. And then we want to have overall cost savings. But the other part of it is, I would say, is undue testing. So, for example, if you are a primary care physician, ask about urine leakage, because oftentimes most people are not ever going to report this. Even when they're coming to my office for, let's say you're coming for urinary leakage. It's a very common thing for someone to come for. We do a very deep screen about all of their pelvic floor dysfunction. There's something called a pelvic floor dysfunction inventory that we do that's really detailed. Not necessary for primary care to do all that, but we dive deeper because we're in that space and we're treating it. What we find out frequently is this same patient has fecal incontinence as well, or is struggling with chronic constipation. One of the things that worsens your urinary incontinence is chronic constipation. One of the number one reasons for nursing home admissions is urinary leakage. So they all tie together. But if you are a primary care physician or any other specialty space, if you're just ask your patient, are they any bowel or bladder dysfunction? They're always going to tell you no. No one ever thinks they have bowel or bladder dysfunction. I even ask people, if you were to say, do you have urinary incontinence? They would say, no, I don't have incontinence. Patients' definition in their mind of fecal incontinence, which is stool leaking out, or urinary incontinence, which is loss of control of urine, their vision of that is that they're wearing diapers and they have no control. But the way that we define it is any unintentional loss of body fluid. So you might say it's minor.
I probably would have defined it the former.
Yeah, exactly. So as a practitioner, screening these things and saying, are you accidentally losing any urine or stool? That's one thing. Are you struggling with your bowel movements? Are you ever straining to have a bowel movement? Hemorrhoids. External hemorrhoids are a really good indication that someone's bowel habits are poor. And just like you guys talk about with the ACO, changing the patient's outcome, 80% of it is behavior and getting buy-in and that sort of thing. 80% of pelvic floor therapy is behavioral modification around bowel and bladder habits. So we're training the patient around things like, if you're having chronic constipation and you're ending up in the emergency room, drink some more water during the day. I mean, it sounds oversimplified, but it's so true. And how many of us don't do things that are very basic that we think, I don't know why, we just don't do them, even though we should. But if you can tie it into the outcome, and physical therapists are very good at this because we're spending 45 minutes with our patient.
Absolutely.
So the GI doctors love us because they're like, okay, you've got outlet dysfunction. go see Laura or go see someone at SmartBody and go through this program to get things restored, then it takes the load off of the GI doctor. It keeps the patient out of the emergency room. But what I'd love for them to do is send them before they do all the testing. So if you have screened, if you're a gynecologist and you've screened and you've found that your patient has urinary leakage, rather than sending them to the very expensive specialists of urogynecologists, which we have fantastic urogynes around town, that urogyne is doing a urodynamic study and a cystoscopy, and then they're sending them to me.
Yeah. Yeah. Well, and that's such a small population of the physician workforce because there's just so few. I mean, you live in a market where it seems like you have ample access, but in my experience is that is a pretty niche.
The
urogynecologist or or gynoc. I mean, those are two very subspecialized niche markets of a physician workforce.
Yes, I'd say that your urologists and that sort of thing as well. But those patients that are finally complaining even to their gynecologist, they're usually getting some other medical workup. They're going on medication before they're getting a referral for pelvic floor physical therapy. I wish it was a standard of care that you have pelvic floor physical therapy before you get put on any of those interventions, or even where I was headed earlier, and we got on a different track is, that those aren't easy tests to go through. Having someone stick something up your urethra, whether you're a male or a female, going through the urodynamic study or the cystoscopy, it's incredibly unpleasant. And it's really scary for the patient. And for patients who have bowel dysfunction, going through anal manometry or having anal defecography, while those are really valuable tests, I believe those things can be done after they've already come and had an evaluation with a pelvic floor physical therapist, which is super cheap. We're talking about a few $100 compared to, a few thousand, and generally speaking. So, yeah.
This has been a great conversation. Again, we talk about value-based care, but it's value-based care along the care continuum. And I think this is a great opportunity and probably a missing element that, again, I've been in this business a long time and I've not had this conversation, but it's going to take all of us working together to make this work. And I think this is a beautiful example of bringing all the care partners to the table to figure out the best possible process to do this and get better outcomes at lower cost, but more importantly, better quality of life. So I've really enjoyed the conversation. I think this has been phenomenal. Thank you so much for visiting with us, and let's move healthcare forward together. This has been great. Thank you so much.
Pinnacle is your partner in the business of healthcare, nationally recognized for helping clients manage risk, improve performance, and drive innovation. For more information, visit our website, askphc.com. For more information on our guest or to learn more, please visit their website,